Okay, well, we have a lot of healthcare providers connecting with us on a pretty regular basis. And, you know, oftentimes these calls are around the struggles they're having in trying to figure out how to engage with folks who might be losing weight, or trying to figure out how to navigate some complicated situations that have come up in the context of a patient they're treating who has an eating disorder. And so I am very excited that we get to talk about communication in this.
Definitely. Yeah.
In this, because I think there's a lot of pieces that we can share about what's worked for us and what we've learned over the years. And I think to set the stage for that, it's important to kind of reflect on why is it so challenging, right? Like, why is it so challenging to kind of work with this illness and with people who are struggling here? And I guess, you know, one of the ways we've come to think about this is that there's this kind of need to shift between a more paternalistic stance, a more like directive approach
Which is more like the medical model.
Exactly.
Diagnose, fix, move on. Yeah.
So we have to move from that and then kind of shift over to more of a motivational approach and be able to kind of toggle back and forth with ease and with some sort of comfort, right? In the context of a condition that can actually be really scary sometimes.
And have a really high mortality. So we're dealing with a disease that has up to, you know, some quote up to 18% mortality.
Yeah.
So it's a fine balance.
It is. And so the communication really is a challenge. And I think that's the first thing to say, is just to validate, yeah, it's hard and it's different.
That's right. That's right. And I think that, you know, once, you know, for lots of physicians that I talk to, when I hear their stories of what they're struggling with and I validate that, there's like an ease that comes over. It says, oh wow, I'm not missing anything.
Exactly.
I'm just sitting with the patients where they're at. And so just coaching other healthcare providers in this area and recognizing it is really hard.
Yeah, it's tricky and it's emotional.
So in this video, I think what would be really important is to go through a typical clinical encounter and really look at 4 key areas to focus when engaging with the patient.
The Ed and Us approach.
The Ed and Us approach. I think we have looked at it in such a way that is how it flows through when we're meeting a patient. And it works really well when we're meeting a patient who hasn't necessarily acknowledged the underlying reasons for the weight loss. And that's what happens, I think, a lot of times in the community, is young people are brought to healthcare providers and aren't necessarily aware or ready to talk about why they've had that weight loss. And so for Ed and Us is engagement, diagnosis and how to discuss that, looking at understanding what's happening for the young person and the family, uniting everyone, because really the team is the family, the patient, and the healthcare provider,
and
maybe a coach, and the system, maybe a coach, maybe a teacher. And then ultimately we need to talk about safety and looking forward of what's the plan going, that follow-up. So that will be the approach we'll look at to help healthcare providers approach individuals with weight loss.
Great.
So I think it would be important to talk about a typical case that might present to a community healthcare provider. And one that would come to mind would be a 15-year-old young person whose parents have been alerted by the school that the teacher is concerned that the young person is falling asleep in class, really not as engaged as they used to be. This was a high-functioning, you know, athletic individual who just doesn't seem to be present anymore. And the parent is stating that maybe they thought there was an issue as well, but they were so excited that the young person had finally taken interest in doing more physical activity and being on a an exercise regime and cutting out junk food, and so even though they knew that their youth was losing weight, they weren't too concerned. But now that the teachers were bringing up all this problem, they're coming to you and saying, like, I don't know, is there a problem? And then you as a healthcare provider who's seen this young person since they were a baby looks and sees this pale, thin, despondent, flat individual, not the young person you saw a year ago. Where do you start with that?
Exactly. Such a common situation too, right at the beginning where no one's really clear what's going on, right? So yeah, that's the start of the approach. So that's the E, the engagement, right? And so thinking about engaging in this sort of situation where there's a lot of ambiguity, right? So we often talk about stance. And in this case, it's a curious stance. What might be going on, right?
That's right.
And I know that there's a lot of ways in which we can frame that and a lot of different kind of statements that we like to make. And we try to keep things as neutral as possible, don't we?
That's right. And I think my two famous sort of introductory questions that I think are really helpful are, one, what's your understanding of being here? Or what's your understanding of the weight loss? And, you know, wait for the young person and the family to kind of just be curious about what happened. And then the second is, and what would be helpful for you that we, you know, discovered today or helped you with going forward? And so really staying in that curious place and not making any assumptions that the weight loss is an eating disorder, but all the while picking up on those signs that might lead me to believe that it is an eating problem.
Absolutely, and you're reminding me of something else that I often will say, which is I'm interested in hearing everyone's perspective. And I don't think one perspective is right or wrong, but I just want to know what's out there and what everyone's thinking, and just being curious and seeing if people are willing to put that on the table.
That's right.
So this starts to flow into the D in the acronym, right? Where we're starting to discuss things like the diagnosis. Because of course, everybody's coming in, you know, wanting to know what's the diagnosis. And as a medical provider, oftentimes you feel a lot of pressure to provide that to people. And yet, if you jump in too quickly, make assumptions, or even just name what it is that you're suspicious of, you can disengage the family and the young person, and then you're going to be wasting an awful lot of time trying to get them back on track, right? And so again, we look at what is your stance, right? And this stance, particularly if you think there's an eating disorder going on, is always agnostic. And there's a lot of reasons why that has to be the case, but it's definitely because we need to keep everybody at the table, right? It's really hard to know also sometimes what's going on. We can sometimes make assumptions, and it's better to sit back and sometimes just think about, what am I actually hearing, without judging or making assumptions about what might be happening.
Yeah, it makes so much sense when I'm hearing you say it, even though this is what we do every day, because when I'm seeing a young person, often by the time they're seeing me, it's the symptoms that are most distressing for them. And that might be the case too when they're being brought to the family physician or a nurse practitioner. It's the feeling cold, or not having the same amount of energy, not being able to concentrate in class, or just feeling disengaged from their relationships, wanting to isolate. And yeah.
So I was going to say, that's where your metaphors come in, because instead of getting into that diagnosis mode, you get more kind of descriptive and using a metaphor for this.
Yeah. And I love metaphors. so for me, this is a great opportunity when I have the sense that they're not ready for a diagnosis yet, but they'd really like to understand their symptoms and why these things are happening. So why am I feeling so cold? Why am I not having my period? Why am I not feeling like going out with my friends anymore? So I often will say, you know, in this, you know, in our society, oftentimes being thin and being fit is really valued. And so there's lots of confusing messages out there that talk about, you know, eating healthy and exercising all the time. But unfortunately, those messages are not meant for growing developing young people. And so developing young people needs so much more energy than a sedentary middle-aged person, which the messages are more suited for. So what I'll say to them is, I value that you want to be healthy, that's excellent. But the ticket that you bought to Healthyville is actually an express ticket to Unhealthyville, because all the things you're doing is actually depriving your body of the energy it needs to be healthy.
So the train.
That's right.
Yeah.
So I use a metaphor of a train, and then regardless of the reason the person lost the weight, they can identify with the symptoms and that metaphor. And I'll see so many young people go, oh, that's it. I just wanted to be healthy. Because I think what they relate to being diagnosed with, say, an eating disorder is this drive for thinness and a vanity associated with it. And so many do not have that in mind at all. Most people with eating disorders have really very little drive for that vanity. It's more to do with being healthy or the control that limiting the food has. And so when I give that metaphor, they're like, wow, yeah, now what we're gonna do is help you get back to Healthyville. That journey might be challenging, but we'll be there to support you with that. Another metaphor that I really like is the campfire or the bonfire. And I think parents really, they tend to smile when I'm doing it because it's so simple, and yet they're able to understand that if the wood isn't going into the fire's starting to go out. And I liken that to their metabolism. So if their metabolism or their bonfire is going out, the systems in their body have to compensate. And so their heart needs to slow down. Their body can't give the circulation to their hands, so their hands get cold. They can't think as well because their brain requires 500 calories a day just to function. Their bowels slow down, so they're always going to feel full and bloated and uncomfortable. They're going to get constipated. They're going to feel dizzy when they stand up. So when I'm able to give that metaphor, then the family is able to say, "That, oh my gosh, that makes sense." And in none of that do you have to say that the person has an eating disorder.
Yeah, they just need more wood on the fire.
That's right.
Yeah.
Yeah. So one of the things we know is that it can be really tricky when not everyone is on the same page. And I think this is the U of our acronym, in that we need to both understand what is going on for the young person, but also to unite as a team. And the team for the young person is going to include the family, but also the healthcare providers, and then other significant people in their lives, such as a coach or a teacher or other people that have influence on them.
And this ties into the idea of getting those perspectives on the table too, because if you don't know what everyone else is thinking in the room, you can feel like you've left with an understanding between yourself and the young person, but they can go home and maybe parents have totally different ideas about what's going on. And when there isn't a shared understanding, it's really hard to make progress. And you can be undermined as a professional, or the parents can be undermined. And what happens in the case of an eating disorder is it just slips through all of those cracks.
I think, and as many young people with eating disorders will refer to eating disorders as, can be the trickiest and the most slippery disorder that we can come up against. And that is one of the things that I have found, that when Ed is in the room, I have to be very mindful of asking the young person and the family what they heard in the conversation that we had. And I'm often I learn and I'm humbled by sometimes what the young person hears that I didn't intend to be conveyed. So I'm always asking, so how did you hear this, or how did the family hear this? And then sort of interpreting that to make sure that everybody's on the same page.
So true, and I'm reflecting while you're speaking, thinking about sort of times where we haven't been able to figure out what's going wrong, why haven't we been able to make headway, when later we find out, oh, it's actually because we had a different understanding than, say, one of the parents. Right. Or we had a different understanding than the family physician.
Right.
So when everyone is not aligned, the patient is the one who suffers, right? Mm-hmm. And we can spend a lot of time just getting everyone sort of on the same page. But what I'd say is that that investment is extremely important, because if you're not investing in that understanding, which sometimes means slowing it down, you're never going to reach that kind of next step in terms of recovery, mm-hmm. right? So bringing everyone together is so important.
And I think something that's coming up for me as you're speaking is, as a parent myself, our number one goal is to keep our children safe, but also we want our children to be happy. And I think sometimes the confusion is that when you're making your child happy that has an eating disorder, often you can be enabling the disease. And so it's really hard as a parent when you see your young person, your child suffering, to do something that feels like you're making the suffering worse, when in reality you're actually helping the young person battle against the eating disorder.
And that's when we can get into those good cop, bad cop situations, right? Where sometimes we're the bad cop and the family wants to be more supportive of the young person, understandably, or sometimes between parents and other care providers, good cop, bad cop, right?
Definitely.
Happens all the time.
And the young person will say, you know, my family physician lets me do X and you don't let me. But then when you have a conversation with the family physician is on the same page as you, but the eating disorder has tried to split the care team. And so I think communication is so essential, to always be understanding and bringing the team back together.
Right. So one of the ways that we try to bring people kind of to the table, even if they hold different perspectives, is by using the stages of change model. So in the stages of change model, we can always reflect on the fact that, you know, there might be, you know, some people who are involved with this eating disorder, mom, dad, grandma, grandpa, coaches, who are very much in action, right? They're ready to go. They believe the diagnosis is an eating disorder. They want to get at it. They want all the referrals done. The young person may be well back in still sort of a contemplative or pre-contemplative mode, going, what's all this about? What's this fuss all about? Nothing going on here.
That's right. I don't feel sick.
Yeah.
Everybody's running around like there's a house on fire.
Yeah.
And I'm good.
Yeah.
Right? I'm happy. There's nothing wrong with me.
And so there's lots of kind of ways in which we see people present in that model, and it can shift over time. But when you present that model to families, you can sort of identify, hey, okay, it's not that we're not on the same page, we're just at different points in this journey. Right? And so it's a way to take people who might otherwise leave and kind of be in conflict with each other and frustrated and why don't you see this, and kind of getting into some of that really heated discussion. It's a way of saying, look, this is normal. We can be at different points along this continuum, and that's a way that they can have a language with which to speak about their differences.
Definitely. And I think I've seen lots of sort of reassuring nods and almost like those sighs when I say to a young person, I'm going to be where you're at and move along with you, recognizing that you are pre-contemplative or contemplative. I'm also going to keep you safe. And this sort of leads into when we start talking, which is the S of our acronym, is around safety. Because if we don't have some some groundwork for safety, we really could get into situations where we actually have to make decisions that go against where the young person is at.
Yeah, absolutely. It's really, really hard to be doing this nimble dance that we're talking about when all the while as a provider you have this sense that, you know, safety and risk is something that you need to be aware of, right? So, you know, I think that it's really important to put that on the table right at the outset so that it can be clear, right? And you have a great way of doing that, and you do it all the time, so maybe you could speak to that.
Definitely. I think this is the S, or the safety, that we talked about earlier, in that, you know, and in the same sort of breath of me talking about being curious about, you know, how they understand the, you know, the weight loss in their lives or what they need, I also like to speak about that there are some things, I call them non-negotiables, that might come up that will change the course of the way we proceed. And so we are going to move and flow with the individual and where they're at, with the exception of a few things. So if there's a medical instability, so they've become they have a very low heart rate, or they are fainting, or they're very malnourished, we might have to step in and hospitalize them. Or if they become suicidal, or there's other things that put them in imminent harm, that moving through the stages of change might have to be interrupted for those things that keep them safe.
Yeah. And I think that ultimately really does help you with rapport, because you're being honest at the outset. And you're also signaling to parents that, hey, I might be doing this a little differently than what you were expecting, but you need to know that I am keeping a watch on this, I'm having an awareness of this, and I'm not going to kind of let this deterioration happen endlessly, right? And you know, my hope is with that, it can help families to feel a little bit less like they need to be the doctor and the nurse and everything, right? When they just need to kind of show up as families and work to navigate the illness. So
I think you bring up a really good point, because often families, when you say that and you talk about the non-negotiables and safety, it's almost like a sigh of relief, because they, all the time before they've presented to your office, they've been the food police, they've been the safety police. Yeah. And they have lost the ability to just have that relationship with their young person as a parent. And so now you can be that watchful eye for them. And I think that's a huge relief in the time for them.
It's that team approach that we're working towards. So.
Definitely.
Yeah. You know, with all of what we said in the ED and US acronym, I kind of want to go back to the beginning and just really emphasize that this is hard, right? It's emotionally really challenging.
Definitely.
For anyone, no matter how long you've been doing it, because you're wanting to kind of be compassionate and understanding, you're wanting to monitor the medical, you're trying to be open to everything that's going on, and trying to kind of hold all of that in a session. And you know, you and I talk a lot about professional burnout, and we talk a lot about, you know, what the toll is with some of this work. And I wonder, is this the right time to talk a little bit about the Navigate kind of acronym that we also like to use for professionals?
We do love acronyms, don't we?
We do.
We do. Yes, because I think how we actually came to the place of working with professionals around emotional regulation and well-being is that so many were coming to us with questions around these complex biopsychosocial presentations. And so, being an adolescent medicine specialist and a child and adolescent psychiatrist, we have built ways of approaching these things that allow us then to process and move on and be present. So Navigate, I think, is a great way to share with other healthcare providers how to do that and still be able to show up in these complex situations.
For sure. And, you know, a lot of it relates to just being attuned to yourself. Notice that it's stressful. That's okay. You can notice that within yourself. And in fact, it's really important to do that, right? But within that, you can also attune to the present moment and continue to have that introspection around, okay, how am I doing with this? And am I attending? And sort of having a framework with which to operate can allow you to kind of process your own emotion as you're going through all of these kind of complex conversations.
And then once you've attuned, as you spoke to, the V is the validation. And there's so much to validation in every interaction, not just with patients with eating disorders, it's with every patient interaction. If someone comes and they're really concerned about something in that moment, giving a term of validation and helping them in that moment is going to really help you with your communication and your own ability to have that introspection of what's happening in that situation.
Yeah, for sure. Slowing it down, being empathetic, and just kind of giving yourself that space. It actually, I think, helps to contain the session for everyone when the provider can be in a calm place.
That's right. And I always go back to, you know, guessing gently about what patients are saying. So, you know, if I just assume I know what they're saying, I often get myself in trouble. Right. So, you know, if they say something, I say, I think I heard you say that. Did I get that right? And that gentle guessing really helps me get the understanding from the patient's perspective. But you can't get that unless you're totally present in that moment with them.
Yeah. And I think the simplest way to do that in that sort of accurate reflection is literally to say back to someone what they've just said to you.
Right? Like really affirm what they're saying.
That's it. Yeah. And so, you know, if you're stuck, you can always repeat back, because that way, for sure, they're going to know that you have listened at the very least, and listening is so incredibly powerful.
That's right. And sometimes patients will say, that's the first time I think someone really heard what I said. And really, you're just saying what they said. But the only way you can do that is really be attuned and present with them.
And that's really the only way to actually get through the Ed and Us approach successfully.
Definitely. And I mean, to finish out our kind of navigate approach is that you want to be truthful to yourself in every interaction, that you're really hearing that kernel of truth for the family, even if the emotions are high and even if it's going against some of the things that you believe in the scenario. There's always a kernel of truth of what is starting an emotion for an individual. So trying to be truthful in that moment to yourself and what you're experiencing, but also what the family is experiencing. And finally, of course, we all want to have empathy.
Yeah.
Empathy for ourselves, but also empathy for everyone that's, you know, struggling or battling with this disease.